I hope we are live now. Good evening everyone. I know by the time most of the question answers you all must have discussed, but still for my all lovely and dear students, this is your pediatrics faculty, Dr. Ashutosh Aggarwal. Right, we'll be discussing, and if I say basically what was the pediatrics part this time, as usual all the topics they had the questions. Genetics 2 question, nutrition again 2 question, you can say neonatology again 2 questions were there, intrauterine infection 1 question, congenital heart disease 1 question. So everything basically there was as the INICET pattern is there, milestone 1 question. So the always what we say the topics they ask, the same topics were there, right? So not wasting much of your time, going to the first question. Out of the following, which statement is incorrect? Which is incorrect, the point is here, regarding the attachment during the breastfeeding. So it was basically the incorrectness. And to solve these questions, we basically should know what are the signs of the good attachment. The baby's chin is close to the breast, that is there. The baby's tongue is under the lactiferous sinus and the nipple is against the palate. Baby's mouth is wide open and the lower lip is turned outwards. The lower lip is basically turned outwards. More areola is visible above. Two things, right? Lower lip is turned outwards and the more areola that is visible above, that is there. There is no pain while breastfeeding. Baby's cheeks are full. They are not hollow, and regular, slow and the deep sucks are there, right? So if you particularly go to the question part here, inverted lower lip, no, that is not inverted, it should be basically everted. So this is an incorrect statement, and that is something they have asked in this question. Full cheeks during feeding, yes. Infant chin should make contact, yes. Areola visible below more, no areola visible below, sorry, below more, it should be above. So this is again an incorrect statement. So as according to the students, there was a multiple answer type question. So the choices A and D, they both are the incorrect here. Both choices A and D are incorrect here. Going on to the next question. 3-year-old child comes with history of becoming cyanosed during crying. Out of the following, which finding present is suggestive of TOF? So they are basically giving you a history of the hypoxic spell. And when I teach you the hypoxic spell, I always say this can be seen in TOF and this can also be seen in the tricuspid atresia. This can be seen in the TOF, this can be seen in the tricuspid atresia. In the TOF particularly, there is right ventricular hypertrophy, tricuspid atresia, left ventricular hypertrophy. In the TOF, there is infundibular pulmonic stenosis, and due to this infundibular pulmonic stenosis, there is a pulmonic ejection systolic murmur. But this pulmonic ejection systolic murmur is not heard at pulmonary valve area because it is subvalvular. So this murmur is heard at the mid left sternal border. This is heard at the mid left sternal border. In the tricuspid atresia, there is LVH and there is VSD, which produces a murmur of pansystolic murmur. So if they give you a hypoxic spell and in the MCQ they give a pulmonic ejection systolic murmur or simply ejection systolic murmur, your answer should be TOF. But if they give you pansystolic murmur, your answer should be tricuspid atresia. Remember, in TOF there is no murmur of VSD. There is no murmur of VSD here. So here infundibular pulmonic stenosis, that is the right answer. LVH would have been the answer if it was a case of tricuspid atresia. TGA does not carry any meaning, and there is no interatrial septal defect. There is the ventricular septal defect. There is particularly the ventricular septal defect is there. Next one, out of the following which represents marasmus? Now in the marasmus, what basically is there? There is no loss of protein. So this obviously is wrong. There is no loss of the protein. So what is there is calorie malnutrition. There is the only deficiency of calorie and the proteins are not lost. That is particularly the answer is there. Now they have also given low cortisol, increased insulin. So for the future things, we should also remember what are the hormonal changes which takes place in malnutrition. So first we consider the growth hormone levels. In marasmus, they can be normal or high, but in kwashiorkor, they are very high. Now you might think why particularly in the kwashiorkor the growth hormone is high? Because what happens here is there is beta cell dysfunction. In the kwashiorkor there is particularly beta cell dysfunction, and due to this beta cell dysfunction the amount of insulin is decreased. That is written here. Also the insulin growth factors production, that is decreased. So because the insulin growth factor production is decreased, the growth hormones become high. Cortisol levels can increase in both. They can increase in marasmus also, they can increase in kwashiorkor also, but they are more increased in marasmus. And these glucocorticoids mainly increase due to the stress, or they increase due to the infection. Then remember the insulin levels. Insulin levels are low here in kwashiorkor, right? They can be normal in marasmus. Why they are low? Because it is beta cell dysfunction. Why beta cell dysfunction? Because in kwashiorkor the growth hormone levels are increased, so called. So they basically cause the damage to the beta cells. They ask them to produce more insulin. So beta cells can be damaged. They can be exhausted. So please remember these things also for the future MCQs, that what happens to the hormones in the malnutrition. So in the marasmus they have asked the cortisol level should increase. This is wrong, and the insulin level particularly should be normal in the marasmus, and it is low in the kwashiorkor. High it cannot be at any case. Next one, 9-month-old child comes with history of not able to sit without support. Yes, this is a thing, if you say a sign which says there is a gross motor milestone developmental delay. Child speaks mama, dada without any meaning. Right? Yes, speaking bisyllables indiscriminately at 9 months is something which is normal is there. Child shows danger anxiety, which is basically comes at 6 months. Man, this 9-month child, it's okay thing, right? And is able to roll from prone to supine, which normally comes at 6 months, right? So what is the next appropriate step in the management? Now this is the some things which you should remember, the red flags in the developmental screening and surveillance, and my source is Nelson page 179. I'm not quoting OP Guy, I am quoting is Nelson page 179. The child is sits unsupported by 12 months, then it is a question of worry. The child sits unsupported, right? He sits with support but unsupported, walks by 18 months. Now again the thing asks you what is next to be done. You should check the creatinine kinase. The child starts running by 24 months. It is a question of worry. Reaches for objects by 6 months, again a question of worry. Points to show you something interesting by 18 months. This is the red flags here. So here it is a 8-month-old child, right? So there is particularly nothing, no developmental assessment is required. You only need to reassure the parents. So the right answer here is particularly to reassure the parents is there. Next one, 36 weeks gestation has come with complaints of respiratory distress since birth. Child needed 30% of oxygen at birth. Chest X-ray is shown, right? And many students said, sir, we could not judge that this is particularly TTN. Now just remember, at 36 weeks, surfactant production is over by 35 weeks. So you are given here a child of 36 weeks. So this cannot be a case of respiratory distress syndrome. right? Pneumonia, there should be something being given, because pneumonia is a presentation of early onset neonatal sepsis. So this particularly is also not true. Meconium aspiration syndrome, this is particularly seen in the term or the post-term child, late term, or you can say particularly. So does not make any sense. So the right answer has to be the TTN. I cannot say the exact X-ray was this, right? But particularly what you get here is sometimes you can get the presence of fluid in the fissures. So you get like these fissures, which are the prominent or the bulging fissures. Next one. Out of the following, which mechanism explains the breast milk jaundice? Breast milk jaundice, which is usually seen particularly in the second or the third week of life. Second or the third week of life. And I have just taken exactly the lines what is given in the Nelson. What it basically says, the etiology of breast milk jaundice is not entirely clear. Although intestinal beta-glucuronidase results in deconjugation of bilirubin and increased enterohepatic circulation, and other factors in breast milk might interfere with bilirubin conjugation, which includes pregnenolone and free fatty acids. Right. So if exactly these were the lines which were being given there, so according to this statement is correct. Although only this much is correct, there is decreased conjugation, because beta-glucuronidase does not causes the decrease in conjugation. This basically leads to the increased amount of the enterohepatic circulation. In refeeding syndrome, hypomagnesemia, hypokalemia and hypophosphatemia is due to. Right? You might say why we are taken, because in my whole lectures in regular feeds, I teach you the refeeding syndrome, and I teach you particularly a malnourished child who was suddenly given a high amount of glucose. So if you give a high amount of glucose, what will happen? The utilization of glucose will be increased in the cell. So magnesium will move from the blood vessel to the cell. Potassium will move from the blood vessel to the cell. Thiamine will move from the blood vessel to the cell. Phosphorus will move from the blood vessel of the cell. But why? Because in the refeeding syndrome, due to the sudden amount of glucose, there can be sudden release of insulin, which particularly increases the utilization of glucose. This particularly increases the utilization of the glucose, right? So in the refeeding syndrome, this particularly features are due to what? This is all due to the sudden release of the insulin is there. Next one, 4-year-old child has broad-based gait. On examination, there is hyperreflexia, positive Babinski reflex, sign of the upper motor neuron lesion. Now, according to the student, there was also a line, there is presence of cringing behavior, right? If it is being given the behavior disorder is present, then your answer is acute disseminated encephalomyelitis. If this line was not given, then our answer is cerebral palsy, because this is all recall based questions. So if it was given cringing behavior, then our answer should be acute disseminated encephalomyelitis. ADEM is there, right? And I have taken all the things, some important things related to ADEM. Reference is Nelson page 3723. This can occur at any age. It is an inflammatory demyelinating event of early childhood. What is the hallmark feature? Encephalopathy, which can easily explain the behavioral changes. This can range from the behavioral change and persistent irritability. There can also be presence of motor and sensory deficit, and the treatment is high dose intravenous steroids. Right? So this was again a small thing, but remember behavioral changes. So that means parenchyma has to be involved somewhere, which can explain these changes is there. So the right answer, if it was given cringing behavior, is ADEM is there. Next one, 6 weeks old child has non-bilious but forceful vomiting, non-projectile since last 3 weeks. On examination, abdominal examination is normal, normal bowel movements out of the following, right? A simple thing, cow's milk protein allergy, you will not give a 6-week child cow's milk, unless and until specified, this is totally ruled out. Non-bilious vomiting rules out intestinal obstruction. Congenital hypertrophic pyloric stenosis, they have written normal bowel movement. So this particularly, their students said GERD, but according to me, it should not be a disease here. It should be gastrointestinal reflux. GER should be the answer, because there is a difference between GER and GERD. Right? It is a physiological process which can be seen in infants. In GER, there is no weight loss, but in GERD, there is significant weight loss. In GER, no respiratory symptoms, but apnea, cyanosis, wheeze, recurrent respiration, pneumonia can be seen here. In GER, no symptoms of esophagitis. Here it can be dysphagia and lower chest pain. Here there is no neurobehavioral symptoms. Here Sandy-Fire syndrome, which is the abnormal neck hyperextension with torticollis, can be seen. So according to me, it should be gastroesophageal reflux, not disease. Disease is something different that is associated with weight loss, respiratory symptoms, symptoms of esophagitis. There can be neurobehavioral symptoms. So that was not there. So according to me, it is simply GER is there. Next one. Child presented with petechiae purpura has platelet count of 10,000 cells. On bone marrow examination, increased megakaryocytes. So there is thrombocytopenia, and that thrombocytopenia is being compensated by increased amount of platelet production from the bone marrow. So that means there is something which is destroying the platelets outside. So therefore, this is a picture of acute ITP. Remember, in acute ITP, you will never get a hypocellular marrow. You can get normal or increased number of megakaryocytes. So if there is normal or increased number of megakaryocytes, what is to be done? Basically, out of this, the answer is IVIG. Ideally cases, the ideal answer is parents have to be reassured. If that is particularly not there, steroids can be given, but still IVIG can be given, although it is never always given in all cases of acute ITP. Next one, out of the following, which vaccine is contraindicated in a patient with severe combined immunodeficiency? And this is something I told you particularly in the DVT session. In the DVT, I specifically discussed vaccination in a person with primary and secondary immune deficiency, and we had this T lymphocyte defect, SCID, and the DGeorge syndrome. And what is contraindicated? All live vaccines are contraindicated. All live vaccines are particularly contraindicated. So this was particularly a slide of the DVTs there. So out of this, if you see, hepatitis B is not a live vaccine, DPT is not a live vaccine, inactivated polio is not a live vaccine. So which is a live vaccine? Mumps, measles and rubella. This is particularly a live vaccine. Next one, out of the following, which is not a feature of Turner syndrome? Webbing of neck, yes, it is seen. Prominent occiput is a feature of Edwards syndrome. Edwards syndrome. In Down syndrome, what you get is mid-facial hypoplasia with flat occiput. And in Edwards, what you get is mid-facial hypoplasia with prominent occiput. Right? Widely spaced hypoplastic nipple, short fourth metacarpal. Right? So this all three are there. But prominent occiput is particularly not a feature of the Turner syndrome is there. Next one, out of the following, which is not an aneuploidy? Aneuploidy means abnormal number of chromosome. Abnormal number of chromosome which are not exact multiple of haploid number. Right? So all monosomies and trisomies, maybe a monosomy or maybe a trisomy, they are considered to be aneuploidy. So this is a trisomy, this is again a trisomy, this is a trisomy. So all monosomies and trisomies are aneuploid, but Bloom syndrome is a disorder of DNA repair, defect in DNA repair. So this is particularly not an aneuploid. This is particularly not an aneuploid. In a 12-year-old child having SLE now presents with nephrotic range proteinuria Renal biopsy shows wire loop lesions. Wire loop lesions are seen in type 3 and type 4 of the lupus nephritis, where there is basically subendothelial deposits. Right? Type 1 minimal mesangial, type 2 mesangial proliferative, type 3 and type 4, which are particularly the important one. There are subendothelial deposits, and there is you get the wire loop lesions. And in this case, you always prefer the combination therapy. So what we give is the IV steroids plus cyclophosphamide. So we are giving here is the IV steroids plus cyclophosphamide. Last question. As pregnancy advances, there is higher risk of transmission higher risk of transmission. They're not saying maximum damage. Now, this is something you should remember. Cytomegalovirus, although it was not in the choice according to the students, it has got the highest risk of transmission in third trimester, followed by toxoplasma. And the rubella has got a very low risk, and herpes simplex virus is mainly transmitted intrapartum. It is not transmitted transplacental, and HIV has got 30 to 40% risk. So next time they can give you cytomegalo, toxoplasma, rubella, herpes simplex virus. They can ask you the least risk. Least risk is herpes simplex virus only. So out of this, I don't know the 4 choices, but if these were the choices, then the answer here is the toxoplasma. So according to me, these were some of the questions which I could get from the students, which were asked from the pediatrics part. And pediatrics, as usual, is not particularly that difficult this time. As always, INICET exam, 10 to 15 questions, you can say 1 or 2 questions can overlap with pathology regarding the genetics part. Rest all the questions are there. If there are particularly anything, any changes, and you can recall any more questions, please send me on the Telegram group. All the best for your NEET exam. Do carry on. Thanks a lot.